Hello and welcome. I'm your host, Ramesh Kumar, and I'm on a mission to bring value to the healthcare industry through improved transparency. And my goal from this podcast is to give you one aha moment that you can implement in your business, whether you're a TPA, broker, or an employer. In my day job, I run a company called Zaki Point Health that helps self-insured employers and their employees provide transparency, direction, and value by delivering a digital front door for the member that proactively steers them. Please like or share this podcast on your favorite podcasting tool so we can bring together a community of like-minded professionals. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org. Our new sponsor for the 2024 season is Valence Health. Valence Health is the platform to simplify healthcare, the destination for employers, payers, providers, and members to reduce costs, improve quality, and elevate the healthcare experience. The Valence mindset and culture of innovation combines to create integrated solutions. Valence engages early and often to execute across the entire patient journey, from care navigation and management to payment integrity, plan performance, and provider verification. With a 99% client retention rate, Valence Health elevates the expectations to a new level of efficiency, effectiveness, and transparency where smarter, better, faster healthcare is possible. For more information, visit valencehealth.com. We have a banger of an episode on a topic you want to learn a lot about. I have with me Oliver, CEO of Key Benefits Administrators, to talk about how to leverage direct contracts with local health systems to create a direct-to-employer offering. And what is the value? We are covering a range of key questions today. Things like, what is D2E, direct-to-employer, in plain English for a self-funded employer? How do these direct contracts actually work on the back end and serve the employers? How is it better than RBP, reference-based price, and the benefits of direct-to-employer? And what are the downsides? What happens when the provider is not available in your limited network? And how technology can actually improve the direct-to-employer offering? So come and join me to learn more. Oliver, I'm so excited to have you today on our session. I've been thinking about the whole world of direct-to-employer and some of the work you've been doing, Oliver. So super grateful for you joining us and sharing some of the learnings. Rather than me try to introduce the depth of all the experience you've had, why don't you tell our audience why they should listen to you and a little bit about your background that relates to the work that you're doing today, and why should our audience pay attention to your insights?
Well, Ramesh, thank you. Thanks for having me. Nice to be on the Voices of Self-Funding and speak to a community that is close and near to my heart. So why should they be listening to me? That's a great question. I don't do a great job of talking about myself from that perspective, but I can tell you this is that from a young age, I've always had a connection with innovation. I placed second place in fourth grade in our national invention contest in my science class. So nationally, I came in runner-up. And I knew at a young age that innovation and creativity was something that I really liked and would thrive in. And when I found KBA, Key Benefit Administrators, I noticed that it was a company that thrived off of innovation. Many of our peers would describe us as one of the most or the most innovative TPA in the marketplace. And I think that alone is worth listening to. But I've been with the company, it'll be 20 years in May. And I've held a lot of different roles. I've played in about every pillar of the self-insured space, from stop loss to the administrative function to agency work. I've got a vast amount of experience, and creativity has really just been where I've settled in here today as president of the company. And really am fortunate to be a part of an organization that's been around for 45 years this year, and was one of the founding third-party administrators back in 1979. So very blessed with a really good company, but also being able to share some of the things that we're able to do as an independent third-party administrator that others are not. And so that allows us to have a creative sandbox that many don't have. So we're a large organization, but we're nimble enough to be creative and to be innovative. And that's a really fine balance that I like to think that some of my BUCA competitors can't replicate.
Well, I'm excited to learn more about your innovation prize. Maybe we can learn more in a separate podcast there. But bringing that innovation mindset, perhaps if you could delve into a bit more, what are some of the things that you're innovating on, particularly when it comes to this whole direct to employer offering?
Yeah, absolutely. Direct to employer is a term, if you're in our industry, you may or may not know about it or have heard of it. But it really is, if I put it on its foundation, the foundational principles of self-funding are really simple, giving an employer control of their healthcare plan and their healthcare spend to create stabilization and to improve and manage the health of the population that they offer their benefits to. And so when you think about a direct to employer arrangement, it's connecting employer plans to the providers of medical care. So again, that direct connection, so getting the folks out of the middle. And we feel like that isn't innovative as much as the way in which we're doing it, where we're making a connection with all of the stakeholders who are a part of the self-funded plan's performance. And we've done this in a way to where we will go into a community and we will partner with a provider system and create a health plan that we offer to the employers in that community. And we make sure that the employer and the provider system have a direct connection and there's an incentive for both to succeed. And it really creates this community initiative. And when you can talk about improving the health of the community, it's a much different conversation. And our vehicle is the self-funded plan. And the innovation around it is how do we create this solution that makes sense for employers and also makes sense for the members, the employees and their families that are on their health plan, and also help the provider system grow and thrive. So all boats rise in this scenario, and everybody in that equation has aligned incentives. And we're really excited about that. And that's really at the heart of our innovation in the DTE space, is bringing those parties together in a solution that we know is different than what they would get elsewhere.
And so, Oliver, if you could expand on this macro benefits of this offering where you are working with a provider. So you're presumably working with one provider system in an area. And when you say the benefits to the provider, to the patient, to the member or community there, what are those benefits? Have you done some of that thinking and validation?
The benefits to the employer and the member are different but similar. And if you zoom out, we're talking about the financial element. So an employer needs to have some kind of a financial control in place, and that's what they have with the self-funded plan. And then we add on to that a preferred contract with that provider system. And so right out of the gate, they're getting a discount by going to the partner system. And then the member is having a financial impact as well. And that is through reduced deductible coinsurance out of pocket all the way to $0. So when we can take away the stick, which we've been using for so long, which is deductibles and out of pocket, and give them some carrots, which are $0 copay, reduced or eliminated deductible, and we send them in to a partner that gives the plan preferred pricing, we see a huge financial advantage. And so our plans steer people into those provider partners. And I can give you an example. So we have a partnership in Fort Myers, Florida. We had a 200 life mid-market group. We took them away from a fully insured carrier, put them onto this DTE plan, and we had over 81%, between 81 and 82% steerage into our partner provider system. And that created, after their first year, a total savings of about $250,000 that they realized from what they would have had if they were to stay fully insured. So we know that this is working, and it's working not only from the steerage, so sending them into the providers, but the providers are incented to make sure that they not only get them into the system, but they get them into the system and they get them healthy. And they're doing that in a way to where we are increasing the opportunity for these employers and these members to create savings and also improve their health.
Let me dig a bit more. So the way these plans are working is the provider is effectively getting a fixed payment premium for the population of those 200 employees, or they're just getting paid based on the pay-per usage. So what does it look like for the provider?
The provider contracts with us, and they will provide a contract like they do to any other payer that has a certain discount percentage for the services they provide. And their incentive to work with us in this arrangement is the steerage of members into their facilities. And so it's for the services provided. But what we're doing is we're really going upstream. So a lot of systems have diabetic programs. They have heart programs. And so when we can engage and steer people into our partner provider system, we then have the opportunity to take somebody who may just be a high blood pressure, high cholesterol patient and really help them work through their eventual healthcare journey. And the provider systems know that when they can engage early, they have somebody in their system for an extended period of time. There's no way to avoid your eventual entry into the healthcare system. They know that. So when we can start to take people away from their competition and bring them into this system through partnership, they're seeing obviously increased revenue, but it's even the retention of the patient that they really are focused on.
So again, on the provider side, you mentioned 80 to 81% stage within the system. What would have been the case otherwise if there was just whether it's a fully insured or self-insured plan?
Yeah, it depends on the community. So it depends on how many provider systems or groups are in that community. But typically you're looking at 40%, 30%. If it's a 3-hospital town, 30-40 is not unique for the leading provider system. Just met with a client yesterday and it's a 2-hospital town and they had a 50-50 split. So for 80% of the utilization to go to one system is pretty unique. And our plan design creates that dynamic. And I will say this is that the plan design is our bag full of carrots, and it's allowing people to have access to the healthcare system at the right time and in a convenient way as possible.
So now switching to that member, the benefits you mentioned, and the employer, they save $250,000. What was the baseline we're talking? What percent of savings are we talking about here?
The percentage of savings that the employer realized was around 20%. So that $250,000 was a 20% savings. And they were receiving a low double-digit increase. So call it 10 or 12% on their full premium. And so for them to have a 20% savings, $250,000 was a significant difference. If you think about the fully insured market, they're looking at the experience that they have within that employer group and saying, I need to make sure I build in a margin, and then I'm projecting what we're going to spend. So not only did we give the margin back to the employer, the focus of self-funding, but we also improved the health. They had margin plus. So we didn't just save them the 12% that they were going to get on the renewal. We saved them double that. That's a really good example of how this works. We're not just a rate. We have preferred pricing, but we're helping change the way in which that health plan performs. And when you get both preferred pricing and improvement in health, or improvement in the way in which they utilize the healthcare system, it's a win-win.
And I suspect the improvement in health is in some ways because the provider, now they have this patient for life, or at least for a long enough term, that it's in their interest to make sure that they are managed healthy. Or tell me a little bit more about when you say improved health. What have you seen there?
It's around disease management, population health. When we can encourage somebody to go into a program around their chronic illness, name one, diabetes as an example, and they see that through a partnership, they identify with that hospital system, in Fort Myers as my example, and we get them in there early and we remove the financial barriers. So we let them know that, hey, we've identified that you have diabetes. There's this great program with hospital system ABC, and we can refer you there. And then when they're in there, that's when the health and the lifestyle changes begin to take place. And so you can't avoid some of the things that will happen over time, age or just development of your chronic illness, but you can certainly slow it down. And so when they slow it down, it's savings to the member and it's opportunity for the provider because now they have the patient for life. So we really focus on getting them into the system, but getting them into the system early. Another great example is just a heart scan. So a heart scan that is the prevention of a heart attack or a major heart attack is exactly how we're identifying opportunities for employers. So instead of saying, hey, go find a system that provides a heart scan, we say our partner system is doing a heart scan for your employees and it's free. And it's going to help you as the employer identify future heart attacks and prevent those. And as those take place and people start to really engage in low cost preventative services, it really does move the needle.
So at a patient level, member level, it's reducing access to some extent, 50% of the access. How do you make their lives better?
Yeah, Ramesh, that's a great question. And it's one of the obstacles that we run into is access is already an issue today and it's compounding. So we have generations that are utilizing the healthcare system more and more just because of aging. And we have fewer and fewer physicians graduating from med school. And so we have this supply demand issue that really is universal. And so when we carve out 50% in your example of the access, we're compounding the access issue. And so our focus is finding the gaps. So we look at what that provider footprint is and we find they may not have that specialty and we go out and we direct contracts with that specialty to fill in those gaps. So we make sure that we have no gaps from an access perspective. But then when there's a volume access gap, we're going out and looking for other direct contracts to fill that void if it makes sense. And so that's a tricky position to be in, but we've had a lot of success with it and it is member driven. So the member feedback helps us identify those access gaps. But I use this comparison and maybe it's not a great one, but if you're a Marriott person, the Bonvoy program or name your airline of choice, when you feel that you have a partnership, a specific connection with that organization, it allows you to then navigate this front door of how do I get in to see my doctor. And so we really are focusing on connecting with the members and advocating for them into a partner system rather than just a system in that community. The access issues remain universal, but we feel like the partnership, even in the narrower network, that the partnership allows us to pull some different levers and that allows us to overcome that objection of this is a narrow network.
And I suspect you are still allowing them to use places outside the network. It's just that they pay more or they pay a copay, a certain deductible, which otherwise would be zero. So you're not taking away access, but you're just saying, look, if you were to use these 50% of the places, there is no deductible.
Yeah. And just back to the creative plan design. So we do not limit the access to the other providers in town. They just will have a higher deductible out-of-pocket copay that they would pay. So we're steering through plan design, incentive, and convenience to our partner. And you don't have the advocate holding your hand and you don't have the blue carpet into the other providers. And so that sometimes impacts the decision making of the member.
And so how many markets are we talking that you have this offering? And is this for every size employer or certain size employers, certain geographies that they should be focused in?
So we're in 8 markets today and growing. We have several emerging markets. So it takes a good 18 months to get one of these stood up. But once we have it up and running, it's about a year for it to really start to materialize. So it's not a short endeavor. It's for employers of all sizes. So we go down to as low as 5 employee lives on a level funded basis, and then obviously as large as the markets have. And we're really not focused just on employers that are domiciled or based in that market. If they have a contingent of employees in that market, we have a group in our Louisville market, and they have what we call a slice plan. So they have the Louisville market plan, and then they have everyone else who's spread across the country. And we give them the choice of both. You can go with open access PPO, or you can go with our DTE plan. And we have not only 84% steerage to that DTE partnership, but every year, the last 3 years, they have increased their enrollment into that DTE plan by 100 to 200 new enrollees, new employees. So they're going from the open access plan to the DTE plan. And so the value is there. We're not only looking for employers that have a employee base in that community, but we're looking at all employers that at least have a contingent of employees in that space. As far as the employer types, all are welcome. It is truly a community initiative, and we try our best to help the employers of that community understand that when they put this DTE solution into their self-funded plan, that a portion of those dollars that are going out are going to help all of the causes that your local community provider system is supporting. So if you think about it, you're really putting those claim dollars back into the community rather than putting it into the stock market if you're with one of the BUCAs. So there's a feel-good element about this that obviously I light up about, because it feels like the right way of helping the healthcare system thrive.
Yeah. And that's kind of huge. More employment, and the provider is benefiting, and you are administrating in that market. Let's talk about the access problem a little bit more. How are you addressing that? Are you bringing more tele kind of services to augment it? How is that working?
This is something that hopefully the listeners of Voices of Self-Funding can really relate to. Is there's a lot of different point solutions, and many of them are addressing access. But the way in which you can organize those solutions to solve the access problem is really challenging. And I think it's something that we have found, not a secret formula for, but we have vast experience of working with provider systems who have a lot of different solutions kind of on the shelves, or maybe in the market, or best kept secret, along with the technologies that are emerging in our industry. And we feel from an access perspective, if we can move upstream, so getting people into the right place at the right time, that may not be the ER, the PCP, the specialist, the brick and mortar hospital, or an urgent care, but really allowing them to access the care that's specific to their needs. And so that filtering process takes place, and it allows the PCPs who are overrun right now to really only be meeting with or seeing the patients that they need to see. And so some of that is, Ramesh, the virtual option. Some of it is care to the home, providing somebody with sick care to their children while they're at home working is a huge convenient benefit. And it keeps them from clogging up a waiting room somewhere. Clinics are a big model right now. And so first, it's identification. Second, it's education, and then it's engagement. And when we can do all three of those, and we can steer people into the right access point of care, it not only has a financial impact, but it takes that access issue and it really begins to mitigate what people are saying right now, which is, I can't see a specialist, or I can't see fill in the blank for 3 to 4 months. That's too long. When we can start to take people and put them in the right places, entry points of the healthcare system, we're seeing a really good impact.
And maybe give me some specific examples here. So when you say you identify people, educate and communicate, are you putting them in a telemedicine program or some on-site clinic? How are you helping with that?
The identification is pretty, in the self-funded world, it's pretty easy as long as you have the data. So we know the demographic makeup. When we analyze our data, we're looking at the demographics, we're looking at their past utilization experience, and obviously their diagnosis information. So we have this kind of treasure trove of information to say, okay, Oliver is a chronic ER user, or Oliver sees his PCP and a specialist 6 times a year, and 5 of those are around sick care, and 1 of them is around whatever his ailment is for his specialist as well. And so when we can identify those utilization patterns, we educate and we say, hey, Oliver, did you know that for $0 copay, you can go to this clinic? Or did you know that there's a virtual health path for when you have your sinus infection? So we educate, and then we can see, is the behavior pattern changing? Is Oliver engaged into this communication? And our communication is widespread. So we're not just calling. We're using every method of communication that we can. But that's the big piece, is identifying based upon utilization patterns, and the diagnosis information is really helpful for us. But there's a lot of common trends amongst just demographics, age, and gender, especially.
Yeah. Oliver, one of the things I see across the industry is to educate, to communicate, to engage, particularly when you've got so many different complications on the back end. Okay, you can go here, you can't go there. How do you deliver that? Isn't that a challenge?
Yes. Yeah, it absolutely is. In today's day and age, it's information overload. Google is the most prominent doctor in the marketplace. And there is this feeling of being on an island, and everyone's trying to tell me something that is not always in my best interest. And so when you're communicating to that population, it's really important that you do a couple of things. One is, what's in it for me? We have to make sure that we communicate in a way that the person reading, listening, is understanding what's in it for them. And then simplicity. So Ramesh, you hit it right on the head. Like, this is complicated. There's nothing simple about navigating the healthcare system, but how can we make it simple? And a lot of that is just step by step. Or if you have a question, here's where you can go. Or the most common way in which we open up a lot of communication and engagement is identifying the obvious. Did you have a question 20 minutes after your most recent doctor appointment that you didn't get to ask because you just processed the information? If so, give us a call or come here and we can help you navigate. So I think it's simplicity. I think it's making sure that they understand that there's a resource out there that's not Google. And I think that's a huge success for us.
Any thoughts on technology that you are using or wanting to use to improve that? There's a lot of communication that you're describing here. What do you see the role of technology in helping you with this?
I see AI being a really important role in this in the future, which is the identification. I think the more data that's brought together and the way in which AI can say, this person looks a lot like this other person and this other person experienced X or Y, we think we will identify people more quickly, of course, and more accurately. And so when we can do that, the communication piece becomes a little bit easier because we can be more specific and more refined. But in a day and age where communication is different for everyone, we spend a lot of our time pinpointing what the preferred communication path is. And when we identify that, we see great success. And everyone's different. Some want email, some want to consume information, some want to talk on a phone, some want to text. So it's different, but I think identifying that preferred route is the most important thing.
Well, this is great. So in summary, what I'm hearing is 20% kind of cost savings against the baseline. In fact, more, because if the trend is going up by 10%, benefits to the provider, benefits to the member, maybe a little bit of limitations on access, but taken care of through incentives. So overall works quite well in those markets where you can have this. And some of the challenges around sounds like, how do you communicate and engage those members and how technology can help. Any advice to employers or brokers or TPAs who want to take this approach or who want to leverage what you have?
I think this approach isn't for everyone. And I think the population that really will thrive in this is those employer groups that really want to create a strategy around their health plan. And that strategy includes the well-being of their employees and their families. And so for those that are really wanting to discontinue the status quo and actually become an active part in managing their benefit plan and the health of their population, this is the right arrangement. And there are a lot of moving pieces, and we've been doing this since 2016. So we've learned how not to do it. So if you're looking for someone who has done it and we feel like, and you expect me to say this, that we have the right formula, we're always excited to talk about it and passionate about what we are doing. For those employer groups who are wondering, is this right for me? Am I too big? Am I too small? And I'm always happy to talk because some, it just may not be the right fit for them, whether it's just where their proximity is to these kinds of arrangements. But others, it might be the perfect fit. And then it's navigating the timing and the opportunity. But we look at it this way. If you look at your health plan as just a line item on your budget, and all you want is to make sure that that's remaining stable or decreasing or increasing in a certain range, this probably isn't the right solution for you. But if it's more than a line item and it's a strategy and it's something that you want to control and make it a part of your recruiting, your retention, and your overall business strategy, I think this is the absolute perfect solution for you.
So would you guarantee 20% savings?
We stay far away from the G word, but I can tell you this is that when you think of any other element of your business, when you manage it and you manage it effectively with partnerships, with preferred pricing, with technology, you oftentimes manage it to whatever your desired result is. And that's something that I can guarantee is that you will manage it to that result that you're looking for.
Yeah. So there you have it, our listeners. If you are out there, broker, TPA, or employer, reach out to Oliver and his team. So how can the listeners reach out to you, Oliver?
You can connect with me on LinkedIn, Oliver Ayres, Ayres. I also, my email address, I can give you that. It's OAYRES at key, KEY, benefit, BENEFIT.com. Those are both easy ways to get a hold of me and look forward to talking to anyone.
Wonderful. Well, thank you so much, Oliver, for sharing how things are working behind the scenes for DTE, and hopefully this will bring new ways for employers to manage healthcare.
Yeah, thank you, Ramesh, for having me, and thank you for the Voices of Self-Funding.
And I would like to thank Valence Health, our sponsor of this show. Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people. And tell us about topics that we should bring to you next. Please watch your email for updates and upcoming guests. I'm your host, Ramesh Kumar of Saki Point Health.